So thank you for hosting and organizing this conference. It's truly an honor to be here and speak to you about some of the work that's conducted in my lab. I direct the Movement Neuroscience Laboratory at Northeastern University in Boston, Massachusetts. And the focus of the lab is really to understand the basic mechanisms of virtual reality, and then on the other side, to understand their applications to clinical populations. And particularly, the emphasis is going to be on stroke. Stroke happens to be the leading cause of physical disability worldwide. And although it's not the only neurological disease that causes physical disability, it certainly is a major problem both on families and societies. And so we're trying to address physical disability and stroke using virtual reality and robotics. Why virtual reality and robotics? Just to give you a brief summary, VR holds certain advantages that therapies in the real world just cannot provide. And the one I want to really focus on today is the ability to use virtual reality to create illusions, modify feedback to change behavior. And in doing so, we wanted to not only change behavior, but also to change brain states of activation. And I think that this might have some relevance to BCI control, because then if you can combine virtual reality and modified feedback or visual illusions with BCI control, perhaps you can kind of have a bigger impact on the patient. Now, VR is by no means a new thing. We can see its evolution from the 50s all the way through today's landscape. And the thing that really has evolved a lot in virtual reality is the idea of interfacing sensors technology with visual feedback. And so if you look at the number of publications on virtual reality, they have been exponentially rising. If you look at the industry related to virtual reality, it is booming. So this is a really good time to make your imprint on VR. But really, you really have to understand what in virtual reality you want to improve, because the major problem is not necessarily to present virtual feedback of whole body movements. Those are relatively doable, and there are plenty of off-the-shelf systems out there that allow to do that. The most difficult, the vexing challenge in virtual reality is presenting feedback of dexterous control of the hand and fingers. Okay? And the reason for that is because the hand happens to be a very complicated effector with dozens of joints, dozens of muscles, and many, many degrees of freedom of control. And so translating that to virtual hand models and getting them to move the way a human hand moves is not trivial. And I'll show you some examples of some hurdles that we've encountered on that front. And then the second, part of my talk is going to focus on how we do that and some basic studies in understanding, well, when you have individuals moving and interacting with objects in a virtual world without haptic feedback, are their movements even the same as they are in the real world? Again, when I reach to grasp an object, I have haptic feedback about its shape, about its stiffness, and so on. When I'm doing that in the virtual world, I don't have information about any of those things. So our movement's the same. And then the second part of the talk is going to be giving some examples of how we can manipulate virtual reality to causally affect brain networks and behavior. And I'll end with a sort of a teaser on a randomized clinical trial that I'm collaborating with to show how we're implementing virtual reality and robotics to help patients with stroke in the acute phase, right after a stroke. So the goal, really, for dexterous control of the hand with VR is really to get this kind of movement. But really, what you get, this is my programmer humor here. We have disco thumb, we have, can you play those again? Spider thumb, and mutant hand. It's really not trivial to get sensors, to provide accurate feedback to a virtual reality environment. And so although what you saw in the first video is of a kind of a veridical type of virtual hand movement. It took us about 2 years of programming to achieve just this simple thing. Okay. And so a lot of this work was done by my postdoc, Marius Furmanek, with the help of some programmers in the lab. And so the idea is to get a hand interacting. Can you keep playing that video on the right a few times? Interacting with virtual objects, where you can flip an object, grasp an object, lift it up, manipulate it in the air, and so on. And I want to remind you here that in the real world, the user is really just grasping at air. In the virtual world, using collision detection algorithms, they're grasping a virtual object and can do things, interact with it. This is what the lab setup looks like, where they're performing the tasks on the tabletop. We have cameras that measure arm and hand tracking. We have instrumented gloves that measure finger tracking. And then we have the subjects immersed in VR using an Oculus Rift head display. We're able to do transcranial magnetic stimulation. We want to causally perturb brain circuits. I'll give you a little bit of data on that. Or measure cortical spinal excitability. Again, this is the device that does that. Okay. So what does it look like when the subject performs a typical movement in the virtual world? Here you're seeing the movement in the physical world, so they're grasping, can you keep playing that? Grasping the physical object. Here's what we're seeing in a darkened room. The LED sensors that they're wearing are lit up. In the virtual world, they're seeing the same object over here. As soon as the collision detection algorithm senses that their finger aperture has basically reached the aperture of the object, it turns it red, there's a beeping sound, and they can lift and manipulate the object. But again, what you're seeing here is that in the real world, they're really grasping at air. So the question is this reach-to-grasp movement, when they're doing it in virtual reality, the same as when they're doing it in the real world? Can you play that again? The other thing that we're doing, and I'll show you that data in a second, the other thing that we're doing is we're perturbing the objects as they're reaching for it. So what you're going to see is it's starting out small, and on some of the trials, the object suddenly changes shape. We have it changing location sometimes. We can change its position, and so on, in order for us to study online compensatory control. So really, the virtual reality paradigm, the platform, enables us a lot of flexibility to study the motor system. Okay. And so when we analyze the movement kinematics from the markers that are placed on the subject's wrist and fingers, what you generally see is a remarkable amount of overlap between the kinematics of the virtual environment and of the real environment. This is shown in the red and in the blue traces over here with standard deviations overlaid. This is average of a group of about 15 subjects. You can see that the endpoint position shows some very subtle differences, but on the whole, the kinematics are remarkably invariant, both for the wrist, which is this profile right here, and for the fingertips. Okay? And we can analyze that data by looking at the kinematics for differently positioned objects that are close, middle, and far away from the person, and differently sized objects that are large, medium, or small sizes. And regardless of what we throw at the subject, the kinematics remain invariant between real and virtual environments. And we wanted to take it a step further, not only look at the spatial profile of the kinematics, but look at the coupling between the grasping component and the transport component. And so what you're seeing is that although in virtual reality movements tend to be a little bit slower, and that's what you would expect, the coupling, the relationship between when the peak aperture occurs and the peak transport velocity, the transport component, the coupling between those two is remarkably preserved. So the bottom line here is that without haptic feedback, we can get subjects to move remarkably similarly in VE, or in virtual reality, as they do in the real world. That's good news because that sort of validates the use of virtual reality for fine motor applications. Okay. I sort of verbalized all of this stuff. And so that brings us to sort of the next part of the talk. How can we leverage perturbations in VR, since the movements are pretty reliable under normal conditions? How can we leverage certain perturbations in VR visually to change behavior and change brain activation. And so I'll talk about two types of visual perturbations that we've used in my lab. The first one is what I'll refer to as a gain perturbation or error augmentation. I'm enlarging the error discrepancy between the subject's visual feedback and what they're doing. The second perturbation is mirror feedback. I'm flipping the perception of which hand is moving. They're moving their right hand, they're seeing the left hand move. The error augmentation has been done by a previous PhD student in my lab, Hamid Bagche. I won't take you through the details of this slide, but I'll just show it to you as a video. Let's just play the top left one. For the veridical condition, I'm not changing any feedback. What they're seeing on the screen really corresponds to what they're doing physically with their hand. So they're moving their hand, and they're seeing the same amount of movement in the VR movements. They move 90 degrees, they get 90 degrees of feedback. Top right, please. In the hypometric condition here, the feedback is scaled down 25%. So what they're seeing is 25% of what they're actually doing. And you can see that the amplitude of the virtual fingers are largely reduced. And just to kind of play it one more time with the hands oriented a little bit different, if we can play the bottom video. No? Oh, yeah, there it is. Again, this is the veridical, so it's a one-to-one correspondence. This is the scaled down movement, and we can also scale it up. So, you know, a smaller movement with the hand produces a larger, exaggerated movement in virtual reality. And so I'll only show the data with the scaled down movement for now. And we ran healthy individuals and stroke patients through these types of training paradigms. And the bottom line here is that when you put healthy individuals, when you expose them to this type of error augmentation feedback, what you get, and you do it over a number of trials to the point where they had a chance to adapt. They learned the discrepancy between what they're doing and what they're seeing. They get a 45 to 50% increase in their corticospinal excitability. This is measured with TMS, which is remarkable because their performance plateaus after a while. It's not changing. The corticospinal excitability increase that we're seeing is completely unrelated to any differences in force output or kinematic changes or anything like that. It represents something that's changed in their motor cortex related to the new adapted state. When you put the same healthy subjects through the same paradigm, but you randomize all the trials so that they never have a chance to adapt to the perturbation. So all they're seeing on any single trial is just wrong feedback, erroneous feedback. There is no appreciable change in corticospinal excitability. So again, that change that we saw initially after adaptation is not related to processing error feedback. It's related to some learning that took place. So what happens in the stroke patient who's put through the same paradigm? Well, when they're exposed to the error feedback randomly, they have the same type of increase in corticospinal excitability. It's pretty negligible. It's actually a little bit facilitated, if anything. However, the big difference here is that they don't have as big of a change in their corticospinal excitability in their motor cortex, meaning that something is going wrong in their motor cortex that's preventing them from adapting, physiologically adapting to the newly acquired state that we want them to enter into. This is the data for the lesioned hemisphere, and we also tested subjects with the unaffected hand, their contralesional hemisphere, and the effect is the same. So this is really a bilateral thing. Both motor cortices are not behaving as they should be to learn the new perturbation. So just to summarize this interim result, okay? Corticospinal excitability responds to error augmentation, very little. For the most part, it responds to gain adaptation, to learning. This is suppressed in stroke patients. And so the way I'm interpreting this result is really kind of a pessimist, optimist, realist, and an engineer approach. And sort of comes back to, reminds me of a joke that sort of, you have an optimist and a pessimist standing in a tunnel, and the pessimist sees just darkness ahead of them, and the optimist says, oh, I see the light at the end of the tunnel. And the realist says, oh, I see a train coming. And the engineer says that there are 3 idiots standing on the tracks and I'm about to hit them. So the pessimist in this data is, well, M1 is really a poor target for BCI. Okay, because it's not, for stroke applications at least, it's not responding the way it should, so why target it? The optimist might say, well, you know, maybe, but after extensive retraining, if we give them enough time, we can pull signals out in adapted states that are relevant for it. The realist might say, well, let's look at some other brain areas that might work better. Parietal cortex, premotor cortex, and so on. And then the engineer sort of would say, well, what other visual tricks can we play to maybe get the right signals out of the motor cortex? And so this sort of leads me into the next visual illusion, which is mirror feedback, another trick. Mirror feedback started out as a treatment for phantom limb pain. These are individuals who have had an amputation. They have phantom limb pain, often feeling like their fist is clenching and they cannot release it. This is the phantom limb. When they are presented with a mirror which reflected their intact hand, it often alleviated the phantom limb pain. After some years, the same approach was tried in stroke patients as a therapy to facilitate hand movement. So they would see they would move their non-affected hand, seeing the mirror reflection corresponding to their affected hand. And some small-sized clinical trials showed positive effects of that therapy. And so we wanted to see, what effect does this type of mirror feedback have on neural activation? Is it activating the motor system in the side of the brain that's affected by stroke and that is not engaged in the movement because they're moving their unaffected hand here? So in a typical paradigm, the patient would move their non-affected hand, they would see 2 virtual hands in front of them, and in the mirror feedback illusion, the virtual hand on the opposite side would be driven by sensors in their non-affected hand, and in the veridical case, the control condition, the same side hand would move. And we did these experiments with virtual reality, not with a physical mirror, because we could randomize everything on a trial-by-trial basis, and we can get the whole setup easily in an fMRI environment to measure brain activity. When we did that, oh, this is an example of mirror feedback. Play the video. This is the veridical feedback, the control. And again, the hand is actuating the movement of the virtual hand, so everything is happening in real time. In the paradigm, when the subjects participate in this, they don't see their own hand, which is hidden under the display, or in the scanner, it's at their side. So when we do this paradigm, what we generally see is that when the subjects are performing the mirror feedback task, again, I want to stress here that they're moving only one hand, their good hand. Their affected hand is completely at rest. What we're seeing despite that is activation in both motor cortices and a very, very strong activation in the lesioned motor cortex. The ipsilesional motor cortex is activated just by virtue of the visual illusion that corresponds to their movement of the other hand. And what we can do is we can do dynamic causal modeling to look at not only what regions are active, but what are the networks that are active. How are they interacting? What areas are activating the ipsilesional motor cortex? And what we found was that there's a completely opposite, different network for individuals who have had a cortical stroke versus individuals who have had a non-cortical stroke. Those who have had a cortical stroke, okay, their motor cortex activation is driven from the parietal cortex all the way around through the intact motor cortex back to their ipsilesional motor cortex. In other words, the lesion that is happening somewhere in here is circumvented by activation through this network of the healthy hemisphere. whoops. In the patients who have had a non-cortical stroke, so these are individuals with pontine lesions, medullary lesions, white matter lesions, internal capsule, for example, basal ganglia, and so on, non-cerebellar, though. What you see here is that the motor cortex activation is driven through the contralesional parietal cortex. So it doesn't involve this other motor cortex. So the lesion location plays a big part in determining how mirror feedback affects the motor system physiologically. And this should bear a lot of relevance to BCI, because if BCI is going to be integrated with a mirror feedback paradigm, okay, well, you might want to be extracting signals from very different brain areas depending on what the patient lesion characteristics are who's participating in this therapy. Okay. The other interesting thing that we discovered in the mirror feedback paradigm is that you can't just be sitting there doing irrelevant movements. And by irrelevant movements, I mean things like finger tapping, or rolling a pair of balls in your hand or something like that. These tasks don't require a lot of visuomotor integration. I can do these tasks with my eyes open. I can also do them with my eyes closed. They don't really tax my visuomotor system. What I need is subjects to be performing the task like threading a needle, okay, or tightening a screw or a knob, where visual feedback is required for accuracy and efficiency of the movement. We did this experiment testing two different conditions, one that had a visual goal and one that had no visual goal with the mirrored feedback setup. And what we found was that when we measured brain excitability, motor cortex excitability, it increased only in the case when the subjects were trained in mirror feedback with a goal task, and it did not change. It even actually decreased a little bit when they were doing the same task without any kind of goal. So again, the way mirror feedback is delivered matters a lot if you want to affect brain excitability. So this sort of segues into the last part of the presentation, where I'm going to try to give you some examples of how we apply these types of augmented feedback using virtual reality and robotics in a clinical randomized trial. This is done in collaboration with a very large team in now four institutions: Northeastern University, well, I can't point to Northeastern University, Rutgers University, NJIT, New Jersey Institute of Technology, and the Kessler Foundation, which is a clinical rehab facility with a research focus. And I'm not listing all of the study members here, but this is part of the team. But as you can imagine, carrying out a project like this requires the interactions of engineers, neuroscientists, physical therapists, occupational therapists, neurologists, and so on. So this is a very large effort. The virtual reality and robotic interventions involve about 30 or so games that vary from piano playing to navigating blood cells through an artery, to hammering objects, playing Pong, and a variety of other games. In some cases, individuals don't wear an exoskeleton. In some cases, they do, such as this device, which is called the CyberGrasp. It's sold on the market by a third-party company. And in some cases, they're interacting with a robotic manipulandum, a 3-degree of freedom one, called the Haptic Master. And so these devices can be used both to assist movement for individuals who are very weak, as well as to resist movement for individuals who are progressing and developing strength. And again, feedback, visual feedback in all of these games can be scaled accordingly in the ways that I showed you previously, and we have, depending on the level and impairment type that the patient has. So without going into too much detail about the clinical trial, the bottom line here is that the subjects are all in the first 30 days post-stroke, so these are relatively fresh strokes. Some of the subjects are several days post-stroke, and so they are literally just wheeled into the hospital. They're going through 8 sessions of training over 2 weeks, so 4 days and 4 days. On top of their regular therapy, they're getting 1 hour of this virtual reality and robotic therapy every day for 4 days, for 2 weeks. And we're evaluating them on a number of batteries ranging from clinical impairment tests, clinical functional tests, brain excitability measures using TMS, strength testing, and so forth. I want to take a couple of minutes to describe what kind of TMS testing that we do, because it's a little bit different from the TMS testing that I described in the previous slide. So TMS, transcranial magnetic stimulation, is an approach to measure corticospinal excitability. The way it's done is usually a stimulator is placed over the scalp of the subject. A magnetic field is created, exciting or depolarizing neurons in your motor cortex. If the coil is placed over the motor cortex, the action potentials travel down, decussate to the other side, come out to the muscles, and you can record, quantify that excitability by placing an EMG sensor over the muscle and recording the amplitude of the motor evoked potential. So these are all motor evoked potentials. That's the outcome measure here. If I crank the stimulator up more, the motor evoked potential increases. If I turn the stimulator down, the motor evoked potential decreases, and so on. If I do a bout of exercise, I can measure the effect that maybe fatigue has on my corticospinal excitability. You get the idea. So I can use it as a pre-post outcome measure. This is a picture of a coil superimposed over a subject's head. This is what the motor evoked potential measurement looks like when I record it at the muscle level. There's about a 25 millisecond delay that's related to the conduction time from the head to the muscle. And if I move the coil around, this is where it gets interesting. If I move the coil around, instead of keeping it at one spot, I can record the amplitude of this motor evoked potential over a topographical expanse of my motor cortex. And so this enables me to quantify the location in XYZ space here and the amplitude, in XY space, and the amplitude, which is in Z here, for each motor evoked potential stimulus. And so I can get a heat map, a topographic map of the representation for any given muscle in the limb. And we do this for many muscles in the limb. We go and record from 16 muscles of the limb simultaneously, and we can generate topographic maps for each individual muscle and analyze the degree to which they recover post-therapy, the degree to which they overlap with each other, and so on. So this is really one of the key outcome measures that we're looking at for neural reorganization. Okay, so the first thing that we try to do when the subjects come into the clinic is after a stroke, is we try to classify them. Do they even have a motor evoked potential? Some individuals after a stroke have no evoked motor potential. That's how affected their motor system is. And so we call these individuals MEP minus. They are without a motor evoked potential. Some individuals do have a motor evoked potential. It might be suppressed. Those are what we call MEP plus subjects. This is not our creation here. This categorization has been pioneered by Stenier and colleagues according to the SAFE protocol as a way to determine what the prognosis is for recovery. And it just so happens that there's pretty solid evidence showing that individuals who have a motor evoked potential after a stroke have a much better prognosis for recovery than those who do not. So we really want to see how these two individuals, these two subgroups, differ on their clinical outcomes with our interventions. So I won't mention any more on this slide other than just to give you an idea that those who have a motor evoked potential show very different patterns of recovery than those who do not. Those who do not are typically flatter in their recovery. And I'll show you a snapshot of what we're seeing in the motor evoked potential plus group in a second. Okay, this is an example of the topographic maps that we can quantify for the affected, on this side, and the unaffected side. So these are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15 muscles of the arm and hand. And you can see that this is before intervention, after intervention, 1 month later, that there are changes, subtle changes in some maps, and then there are lack of changes in other maps. So some muscles come back online after intervention, and other muscles don't typically show much recovery. And so we can quantify all this at the group level by looking at the average at the group level, and you can see that for most of the muscles that we record, the affected hemisphere, the muscles tend to recover. This is the size of the map. In the unaffected hemisphere, the muscles initially show some improvement and then kind of peter out and come back down. So the recovery is very different depending on which hemisphere you look at. And in the unaffected hemisphere, there's generally no change in the MEP minus group. So the upshot of all of this is relatively new data that's sort of coming in. Every day we get new results coming in. So I'm just showing you things that are kind of hot off the press here. And this is a correlation between the motor evoked potentials in the affected hemisphere and in the unaffected hemisphere, and their relationship to two behavioral outcome measures. And we found this result to be interesting because this, in the top row here, this outcome measure, is a clinical functional scale called the Wolf Motor Function Test, and it checks for dexterous control of the fingers, so how well you can manipulate objects, fine motor control. The second one, the lower panel, shows just raw force output. How much force can you generate, okay? So there's no dexterity there. And what we're seeing is two completely opposite patterns of recovery. For individuals who have force recovery, what we see is not much change in the motor evoked potentials on their affected hemisphere, but we see a significant correlation with changes in their unaffected hemisphere. For individuals to develop fine motor recovery, the unaffected hemisphere doesn't matter. Doesn't matter what happens there. It's the affected hemisphere that has to change. So we see a double dissociation between the affected and non-affected hemisphere recovery as it relates to either fine motor control or force production. So again, depending on what the goals of the interventions are, the hemispheres matter. The other thing that matters is whether these are acute or chronic individuals. Acute individuals, or subacute that I'm showing you here, okay, in this plot, show both an expansion in the volume and in the area of the cortical map for each muscle. The chronic patients, so in other words, the maps get bigger and the activation tends to get stronger. In the chronic stroke individuals, there's usually not much change in the way of the expansion of the area. And what we're seeing is sort of this paradoxical reduction in the volume of activation after the same intervention, 2 weeks, just delivered to those who have chronic stroke versus acute stroke. So again, our expectations really have to be in the context of lesion location, what the outcome measurement is, which side of the hemisphere we're looking at, and also the chronicity of stroke. So there's a lot of complicated variables here to consider for BCI. So I'll end here with a quick summary of everything. So there's this kind of a literature base that shows that early, intensive, and often or frequency for interventions is what really drives the output, okay? They have to be early, delivered earlier because we can get those nice changes early. They have to be intensive, done many days a week, many hours, and so on. And they have to be done often, every day. You can't just do it once or twice a week. And so what I think that we're starting to see now is that through virtual reality, we can tailor interventions to create also a new dimension here of individualized therapy. And I think one of the past speakers kind of mentioned the individualized component for robotic and BCI interventions. And so my student, there's a US song, Old McDonald Had a Farm, E-I-E-I-O. So my student kind of went off on harmonizing this acronym to EIEIO, effective, individualized, early, intensive, and often. So with that, I'll end. These are the lab members. We're very grateful to the extensive funding that we received over the years, and some of the collaborators on some of the projects are here. Thank you.